On behalf of the National Eczema Association, I'd like to welcome you to our presentation, Understanding the Link Between Eczema and ADHD in Children. I'm your host, Michelle Guadalupe. Today's webinar is made possible in part by an educational grant from Sanofi Regeneron. Our presenter today is Jennifer Moyer-Dar, LCSW. Jennifer Moyer-Dar is a licensed clinical social worker at National Jewish Health in Denver. She helps families and children with psychosocial factors related to chronic illness, trauma and abuse, and anxiety and depression. And with that, I am pleased to introduce our presenter, Jennifer Moyer-Dar, LCSW.
As we talk today, I've been asked to talk about really understanding the difference in the links between atopic dermatitis and ADHD in children. So with that, I'm going to jump in. I'm sure there's lots of questions, but if you will, just hang on to those till the end, and then I'm happy to answer anything I can. Looking at studies that show atopic dermatitis with associated increased odds of ADHD and ADHD in children. And just to say, that'll be the only time you hear me say ADD, other than to tell you why I don't say it anymore. But because of when that study was taken, that is how it was written. We're also going to look at atopic dermatitis and sleep deprivation and how the combination of those two shows an even higher impact on ADHD symptoms in children with atopic dermatitis. What we don't know is how and why. So as we go through this, we're going to talk some about the hypothesis of, why is it that children with eczema or atopic dermatitis seem to present with higher numbers of ADHD? Is it underlying ADHD? Is it more symptomology that looks the same but isn't? Which sometimes happens a lot in the form of mental health. Things present similarly, even though they're separate diagnoses. So we'll talk through some of that. But what we do know is that it's a vicious cycle. So when our atopic dermatitis isn't well controlled, we're more likely to have sleep difficulties. We're more likely to present with inattention, distractibility, irritability, mood swings, all sorts of things. So as we talk through this, just kind of keep that little bit in mind. And we're going to start first with a really quick review of eczema because you all are really the experts on that. I don't need to spend a lot of slides talking with you about what eczema is. So just briefly, remembering that eczema refers to a group of conditions that causes skin inflammation. Atopic dermatitis, or AD, is just one type of eczema. We often use those terms interchangeably, but I always like to remember, while AD is always eczema, eczema isn't always AD. So if I use eczema or AD or atopic dermatitis, I am using them fairly synonymously for the purpose of this talk. Typically, atopic dermatitis or eczema presents with significant itching, rash and inflammation, dry scaly skin, changes in pigmentation, and thickened areas of skin. Can be really painful in some instances and also cause some sleep difficulties. Often that tends to correspond with kind of the extent or the severity of their atopic dermatitis. So we tend to see that more with moderate to severe, although it can happen for any of our kids or adults. When our atopic dermatitis is significant enough, we tend to see significant impact of sleep. And a lot of the children I work with atopic dermatitis do come in presenting with sleep deprivation. So this is just a screen. This is an infographic that was actually put together by one of my colleagues, Lisa Meltzer. And if you're interested on sleep, she has a lot of good articles and resources out there. So you can look up here real quick, looking at your child's age and see how much sleep they typically need. And remember, it's a range, right? So if you have the preschooler, the 3 to 5-year-old, we're thinking 10 to 13 hours over the course of a 24-hour period. So that does include naps. For all of you who are off the adolescent side and into the adult side, sadly, we're expected to get about 7 or 8 hours. And if I could see a show of hands, I would guess many don't get that, especially if your child has atopic dermatitis, because often it's not just one person in the house who's sleep deprived, then it's at least 2. When we think about what presents as sleep deprivation, like what are some of those warning signs? If they're really difficult to wake in the morning, if on the weekends or holidays they're sleeping more than 2 hours extra. And interestingly, tag number 3, ADHD-like behavior is a warning sign of sleep deprivation. These are kiddos who will fall asleep in inappropriate places. As soon as they're in the car, they'll fall asleep in class. They'll be in the midst of an activity and just curl up and fall asleep. And when I say emotional problems, we really are meaning more like emotional dysregulation. There's a lot of highs and lows. Responses are often disproportionate to what's occurring. Over the course of a lifetime for any child, not just a child with atopic dermatitis, any child, 25 to 40% of kids have a sleep problem at some point during their childhood. So knowing that with atopic dermatitis, that's even higher. Treatment interventions when we're talking about atopic dermatitis. Again, you all are the experts and know many of these things already, but we're looking at daily skin assessment and treatments. So a lot of the soak and seal, meaning the 15 to 20-minute baths in lukewarm water, sealing with topicals and or moisturizers, possibly wet wraps. And now we have the added objects of biologics as well. And I've put an asterisk in that because there's been a couple of studies now, specifically, I believe, with Dupixent, looking at children who have met criteria for ADHD with atopic dermatitis. And when they were treated with a biologic, again, I believe it was Dupixent only that we've looked at in the studies, their ADHD symptoms seem to resolve. Now, we're not saying that there's a causal effect, right? We're not saying take Dupixent and it cures ADHD. I am not saying that. However, what we're finding is that we do see a decrease in those symptomology. And we'll talk a little bit about the whys of that. We're also working with treatment interventions for breaking the itch scratch cycle. So distraction and replacement behaviors are huge. How do we break that initial habit or tendency to scratch? Because as you know, some of our individuals with atopic dermatitis will scratch and kind of zone out and they don't even know they're doing it. Others, it is the go-to default response when they are stressed, frustrated, overwhelmed, tired, whatever. We go to the scratching. So distraction simply means how do we change their focus? How do we shift them off of the itch? For a little child, that can be as simple as, blowing bubbles and getting them caught and popping the bubbles instead of the scratch, or a video, or playing catch. Replacement behaviors are doing something other than scratching to the itchy area. So putting like a cold washcloth on the area, applying moisturizer, using a texture ball to roll on the itchy area rather than scratching it. Those are replacement behaviors. And we're going to use both depending on different situations. We also find that parasympathetic work works really well. Parasympathetic work really kind of focuses on enhancing our parasympathetic nervous system. So if you think about, probably ninth grade health or science, you got the whole fight or flight lecture. When we talk about that, that's our sympathetic nervous system. When we're stressed, overwhelmed, sick, scared, don't feel good, that sympathetic nervous system goes into overdrive. Our parasympathetic side is supposed to kick in and bring us back to baseline. It doesn't always work very well for any of us. So doing activities that kick it in, that teach our body to calm back down. So diaphragmatic breathing, biofeedback, some yoga breaths, self-hypnosis, all of those things are parasympathetic inducing and can really help with breaking the itch scratch cycle. I've also used self-hypnosis with some of my kiddos specific to itch and pain, and we've been able to decrease the level of itching and the level of pain associated with atopic dermatitis when we do that. For sleep, we want to use behavioral sleep hygiene and or medication. I am not a proponent of long-term medication for sleep for kids. Most of us as providers are not. However, sometimes we really need it to help reset things. Otherwise, you may see our kiddos are going to bed at 2, 3 in the morning, or they fall asleep at 11 and they wake up and go back to sleep and wake up until about 5 a.m. And parents will tell me get their best sleep from 5 to 10 a.m. So sometimes we do add a medication to help reset the sleep, but then we're also working on all of the behavioral sleep hygiene because many of our individuals with atopic dermatitis haven't really learned to self-soothe or fall asleep independently because of that scratch. We're patting them until they fall asleep, or we're co-sleeping, or we're doing other things to try to prevent that scratching, which no judgment, we do what we have to do to get through a night. But as their skin improves, we want them to be able to learn those skills and master those techniques to do things independently. So with all of that for atopic dermatitis, we're going to put that on pause for a moment. We're going to come back to it. And I want to shift to the ADHD piece. So historically, we used to say ADD and ADHD. That's no longer true. It's now attention deficit hyperactivity disorder with clarifiers. So when we talk about ADHD, it really is a neurodevelopmental disorder that affects development and function. Primarily, we see that in areas of inattention, hyperactivity, and/or impulsivity. When I say it comes with qualifiers, we now say ADHD predominantly inattentive presentation. That's the newer, not really new, it's been there for like 20 years at least, but the newer term that we used to say ADD to. ADHD predominantly hyperactive impulsive presentation. You just sometimes hear people say hyperactive or hypertype. And then ADHD combined presentation means that somebody presents with both of those. They may have that hyperactive impulsive quality, but they're also having difficulty with attention. So like any kind of mental health diagnosis, we shouldn't just willy-nilly diagnose somebody. When we look at ADHD, there's a variety of criteria that have to be met. All of this is per our DSM, which is our Diagnostic and Statistical Manual. We're currently on the 5th edition revised. We're due for a new one sometime soon. I haven't seen it published yet. But regardless, when we talk about that, there has to be at least 6 out of 9 symptoms met for inattention and/or hyperactivity, meaning 6 out of 9 in the inattentive category for me to say ADHD predominantly inattentive, 6 out of 9 in the hyperactive for me to say predominantly hyperactive impulsive, or they've met both categories and then I'm saying combined presentation. Other things with ADHD, we have to see symptoms persisting for at least 6 months. It has to be inappropriate for the developmental level. So if you bring me a 2-year-old who is climbing over my furniture and has the attention span of a gnat, they're probably just 2. But that doesn't mean they're not going to develop ADHD, right? It has to be developmentally asynchronous for us to be able to actually say it's a concern. It has to impact areas related to work or school or social interactions. And we have to see the symptoms present in more than one environment. So it can't just be at school that they're inattentive or just at home. It has to be in more than one environment that we're seeing it. And then we also want to see that typically symptoms were present prior to the age of 12. There are a couple times where we might say that differently, and usually that's a head injury or some other development later in life that's occurred. So pediatric signs and symptoms of ADHD, signs of inattention, often fails to pay close attention to details, has difficulty sustaining attention in work, does not seem to listen when spoken to directly, often does not follow through on instructions or fails to finish tasks, often has difficulty organizing tasks and activities, often avoids, dislikes, or reluctant to engage in tasks that require sustained mental effort. Meaning if it's something they love, they're all in and can attend for 2 hours like a video game. But if you ask them to do a basic chore that they can do but don't like to do, it's often not finished, incomplete, done poorly, and you've told them 12 times. These are kiddos who often lose things and random things. Jackets and hoodies are good examples. Although I did have one child once tell me, I asked, how many hoodies or jackets did you lose last school year? And he told me none, but I lost 3 pair of shoes. And I just looked at him and his mom was like, so, usually things other than shoes, but whatever. These are kiddos who are easily distracted by external stimuli and are often forgetful. So that's all the inattention. Again, 6 out of those. Signs of hyperactivity and impulsivity, often fidgets with hands or feet and squirms, often leaves seat in a classroom or elsewhere, often runs about and climbs excessively, has difficulty playing or engaging in leisure activities quietly, is often on the go or acts as if they're driven by a motor, often talks excessively, blurts out answers before questions have even been completed, has difficulty waiting to take turns, and often interrupts or intrudes on others. So these are, again, signs and symptoms of ADHD per the DSM. I will also tell you that in children, some of the signs and symptoms of ADHD, we see similar signs and symptoms for kiddos who are very anxious. So again, just saying my child has checked some of these off doesn't necessarily tell me they have ADHD unless I'm looking at a bigger picture. So that's always important as we're going to talk through this. I know this is a pediatric talk, but often I'm asked, well, what about adults? Are the signs and symptoms different? So big things for them is, again, difficulty concentrating, a lot of executive functioning difficulty. So real difficulty completing tasks, organizing things, breaking projects or activities down into smaller pieces. With adults, we tend to see more of like a restlessness or a mood swing. It's described often more as impatient than we would describe it in our kiddos, and difficulty in maintaining relationships. Um, Often you can diagnose ADHD in an adult. It doesn't mean they shouldn't have been diagnosed younger. So sometimes it's a matter of they presented this way their whole life, they were just never diagnosed. Occasionally, it has something to do with other health issues or an injury that may have contributed to kind of frontal lobe and executive functioning issues where they now meet criteria as well. So I'm a big proponent of a multidisciplinary approach and a thorough assessment. When I'm looking at someone and trying to assess for ADHD, regardless of whether they have atopic dermatitis, I want to know their medical history. Have they had concussions? Do they have atopic dermatitis? Do they have any other medical issue that impacts sleep, overall functioning, attention concentration? Developmentally, are they on track? Educationally and academically, where are they at and what's their cognitive abilities? What is their sleep like? And not just how many hours they get, because some of our kids can sleep for 6, 8 hours, but they're having all these little mini arousals. They're never really hitting REM sleep. Or they're in bed for 12 hours, but they're only sleeping for 6. And then I want to know a psychological history. So stresses, traumas, family history, because we do know that ADHD is something that trends in families. So we want to really look at this from a whole perspective, not just quickly say someone has ADHD. If someone comes into me with atopic dermatitis and ADHD, looking for an ADHD diagnosis, my first take on that is always, let's get the skin and sleep figured out, and then I'm happy to assess them for ADHD. And it happens a lot where kids will come in, especially my like kindergarten through early elementary. I've had many families come in where the teachers have told them they need medication, they can't pay attention, they have ADHD. And then as we go through the history, and then as we get their skin better, and then as they start sleeping, those sometimes resolve. So sometimes it's not ADHD at all. It's all of those presentations and qualities, but it's due to sleep deprivation and that chronic illness, right? Like we're constantly itchy and irritable and unfocused, but not because it's ADHD. So sometimes we have to take a step back, even though everybody's kind of honest about ADHD and meds. Sometimes we need to step back, treat skin and sleep, and then give it a month and then come back and reassess. Also, if we do like neuropsychological testing or any kind of evaluation beforehand, we get again can say yes, they meet criteria, but we don't know why. We don't know if it's because of the atopic dermatitis and sleep. So whenever possible, I like the order of skin, sleep, and then ADHD evaluation. Keep in mind, again, anxiety and ADHD can present very similarly, especially in younger children. Sleep deprivation alone can lead to an ADHD-like presentation. Things like head injuries and utero drug exposure can impact attention, mood, and executive functioning abilities. And diagnoses are not mutually exclusive. So yes, you can have atopic dermatitis and ADHD. You can have ADHD and anxiety. You can have a variety of these things. And again, that's why it's really important to get a thorough evaluation and not just look at the check sheets, even though I included them in there for you to look at. Not just pull that out and say, yes, my child does or does not meet criteria. So when we talk about interventions to target ADHD and atopic dermatitis, it's not like we're going to target the atopic dermatitis by itself or the ADHD by itself or the sleep issues, right? There's really this sweet spot where they all overlap. And when they do, we get a really dysregulated child. Mood irritability, mood swings, dysregulation, sleep difficulties, disproportionate reactions to small things. Parents will sometimes say like they're just really hard to parent. Or parents are frustrated because they feel like drill sergeants. They feel like they're on them all the time, whether it's telling them to stop scratching or telling them to pay attention or telling them to go to bed. So when we think about these interventions, we're going to come back to looking at them all together. So interventions in general for ADHD, right? I already remember back slide 3 or so, we talked about interventions for atopic dermatitis. Interventions for ADHD. We do a lot of behavior modification with positive reinforcement. So breaking things down into small steps, building successes, rewarding the positive. We do a lot of extinction. So we ignore the negative behavior because otherwise we inadvertently give attention to the wrong thing. We sometimes have to modify our parenting techniques. So what worked for the other 2 or 3 may not work for the child with ADHD. Typically, we need to increase our structure. We're doing a lot of visuals and charts. It's also really helpful at bedtime when the chart says it's time to go to bed rather than mom says it's time to go to bed. So if we kind of create the bedtime routine, what the activities are, how many books, and oh, now the chart says it's time for bed or it's time for snuggles or time for lights out. And being able to tell the child, okay, look at the chart, go check the chart, what's it say? Says time for snuggles. Okay, go get into bed so I can snuggle you and say goodnight. We're taking some of that power dynamic away, right? Because it's really easy to headbutt with a kiddo who has ADHD. We tend to get into these power struggles that just aren't useful to any of us. So being able to create an environment that helps them stay on track, monitor a system, get reinforced, and then as they do that and do that well, we can start to decrease the reinforcements. We would need to build in school support. So whether that's modifications in the classroom, such as a kick band around their desk, or being able to sit in the back so they can get up and walk if they need to, preferential seating closer if it's more inattentive and they need help paying attention and getting back on task, changing out to a preferred activity once they complete something that they don't like. All sorts of different things are really easy to build strategies in at home and at school related to the ADHD. And then you'll see a lot of movement for executive functioning coaching that's typically more with our adolescents. And it really is somebody teaching them how to break down tasks, organize their work, motivate themselves. Like, how do I make myself do something when I really don't want to do it? And there's 12 other things that are more interesting to me. Being able to ask for help, being able to like kind of design a system that keeps them focused, whether that's, a folder system for their homework or organizing backpacks differently. So there are executive functioning coaches as well, and a lot of them are doing some online work. And then there are medication options. So traditionally, we see stimulant medication used for ADHD. Those are things like our Ritalin, our Adderall, or our Concerta. There's also non-stimulant medications such as Strattera and Intuniv. There's pros and cons to both. I am not a psychiatrist, so I'm not going to say I recommend any more than others. However, I do caution families. If we have a child with ADHD and anxiety, sometimes the stimulant can ramp up their anxiety, so we need to pay attention to that. Also, if appetite is an issue, stimulants can decrease appetite. So sometimes we start with a non-stimulant for those classes of kids and see if we can do well with that rather than risking some of those side effects for the stimulant medications. Other meds are sometimes used for ADHD, things like guanfacine, Wellbutrin, and Effexor, which are not traditional stimulant or non-stimulant medications, but they are sometimes used kind of more in the line of taking the edge off a little bit of the irritability and helping with focus. But I don't think anyone would argue that they work as well as the more traditional medications for ADHD. So, whoop, I'm missing a slide. Oh no. Oh well, sorry, I'll just talk. Um, there was a slide in here that really kind of overlaid all of those interventions, right? Because as I said, we're not going to just treat ADHD or anxiety. And when I put them all together, they were kind of on an overlapping slide. It's really kind of obnoxious and overwhelming when you see how many things we're trying to do, because as the adults, being able to navigate that, being able to stay on top of skincare or manage biologics when our kiddos don't like needles to begin with, or sending skincare supplies back and forth if we're in split households, or making sure school has what they need, and also helping them work on attention and concentration and modifying behaviors and learning improved social skills. All of these together can be challenging and overwhelming. So I don't want to leave with that message of it's impossible or too overwhelming to do. That's why I just kind of broke them out. When we think about it more in terms of, okay, where do I want to start? Right? We're going to start with the skin, and we're going to get that really good so we can see what's left. And we're going to work on the sleep, and we're going to get that really well managed as well. And now I can say, okay, do we also need to add in the interventions for ADHD? Is there still concern for that? If there is, a lot of behavioral modification you can implement at home without a formal diagnosis. It works great for lots of kids for lots of reasons. They tend to do better with more structure. And it usually helps us be a little less frustrated and overwhelmed if we have some routine and order to things. So, by all means, find a behavior system that works. Use a chart system. You can look up things online. There's free charts all over the place. But if that's not effective, their skin is better, they're sleeping better, and oh, by the way, they're still getting calls from school because they're out of their chair and they're not paying attention and they're having difficulty getting along with their peers. And when they come home, it looks like a tornado hit and you're telling them things 12 times and you feel like they're not hearing you, then yes, that's really worth a formal evaluation, either with a therapist or we can also assess and do formal testing, like psychological testing, which has additional testing abilities, including some computer tests to better diagnose and tease that out, especially if we're not sure, is it ADHD or is it anxiety, and we just can't tell in the therapeutic environment. If we're talking about medications for sleep, often, families have tried things like melatonin or hydroxyzine or Benadryl. Keep in mind that some of those are really short acting. So even if it helps them fall asleep, they tend to be awake again in a couple hours. So they aren't always the most effective. Hydroxyzine also has an anti-anxiety component to it. So sometimes our kiddos seem better behaved when they take it, but it might actually be that we're, unbeknownst to us, managing some anxiety with it as well, although that's not typically why we give it. Um, a lot of providers will use clonidine to help children sleep and reset. Again, not long term. It's not a medication that was initially designed for sleep. It was actually developed for blood pressure, didn't work very well for that, and has been used more off label for the benefit of sleep onset. And it works really well. So, some of our families, we will use that for a short time period to help reset and get them on a good sleep cycle while also implementing the behavioral modifications and sleep hygiene interventions as well. Things like sleep routines, sleep schedules, doing more destimulating activities closer to bedtime. And then there's always the tried and true tricks for getting them to sleep independently, things like the sleep fairy or the excuse me drill, where we slowly spend more and more time out of the room and reinforce them being in the room. So there's a lot of strategies that many behavioral clinicians can be helpful with. Not all of us are experienced with chronic illness. So if you're looking for someone, that's important to either try to find somebody who has some understanding of chronic illness or be comfortable educating them. Like with their atopic dermatitis, how does that affect their mood and attention? What does that do to sleep? Because they may be things that they're just not experienced with. So being able to talk about a child or an adolescent or even an adult um, from their whole being, right? Not just a piece here and a piece there. Being able to talk about how all of these things are intertwined, how each of them can exacerbate the other, but how also managing one can help improve and benefit the other. So with that, I just want to say thank you for coming and attending, and I'm going to open it to questions.
Great. Thank you so much, Jennifer. That was, yeah, really interesting. And I think we're going to take down the slides so that they could see us a little bit better. But first, I'd like to ask you, is there as strong of a link between other eczemas and ADHD as there is between AD and ADHD?
Um, sorry, I was trying to get rid of my slides. Can you just see me?
Yep, it looks great.
As I was like distracted. Um, I have not seen literature on it as well. I tend to see more of the eczema and ADHD. We tend to see more of the eczema anyway in young children, which is when we're often diagnosing ADHD to begin with. So I can't say it doesn't exist or that there's no literature out there, but I think primarily it's more eczema and atopic dermatitis. I mean, eczema and ADHD, sorry.
Yeah, no problem. And for those listening, if you did have additional questions, make sure you put them in the Q&A box. So I have another question from our audience. If medication that resolves itch and other AD symptoms, they help alleviate the ADHD, can we deduce that ADHD is driven by that itchiness and our discomfort?
I would say the ADHD like symptoms are driven by it. They may not actually have ADHD. And that's the key thing we want to kind of clarify, right? Because we don't want to overdiagnose if we don't, well, we never want to overdiagnose. And we certainly don't want to make a diagnosis if it's not accurate. I have no problem diagnosing ADHD if I truly see it and it's there. But if I have that child, so like for an example, I had a 5-year-old who came into me and they came into our intensive program for atopic dermatitis. And this was one of the families where the mom said, I'm pretty sure they have ADHD. Can we get an evaluation and meds while we're here? I said, well, what makes you think it? Well, and it was all the things I just said. The school was complaining and they couldn't sit still and they were getting into fights with people at school and they weren't paying attention and they were zoning out at home. This is a kiddo that it took about a week to get good control of the skin, and then sleep started to improve and behavior started to improve. So we left it at that time of, I'm not diagnosing ADHD. Let's give this a good solid month. Behavioral interventions, improved sleep, because it takes longer to catch up on 5 years of not sleeping than 2 good weeks. And let's reassess it. And when they called me, they didn't even come back. They just called me and said, he's doing great. I don't think we need to see you. And I said, okay. So he probably never had ADHD. However, if I'd only checked the boxes, I would have diagnosed it because on paper he did, but the behaviors weren't related to kind of that neurodevelopmental. They were related to chronic itching, irritation, and sleep deprivation.
So I know a lot of parents are probably thinking, well, how do I even how would I even get to someone like you, Jennifer? Typically, have you seen that it's the pediatrician or a specialist? I guess we're kind of curious, like, how do they get to you? And like, is it diagnosed before they get to you? Before, someone like you, just wanted to kind of understand that process.
So I have to say my position is fairly unique. There's a few of us, but across the country. But being tied to a medical center, I have the luxury of being able to see kids who come into our medical programs, and we're just part of their care. We run as a multidisciplinary, so they get a physician and a behavioral health clinician, and we're just like the core team along with everybody else we pull in. But I also do outpatient counseling and behavioral health in the same office. So sometimes I'm working with a child who's here in our day program, and I know we're dealing with atopic dermatitis. And when I read the parent questionnaire, they've marked off sleep issues and scratching and doesn't pay attention. Like it's all just laid out there for me. And my job's to tease it out. Sometimes I get the referrals from the community, and I'll have a child come in thinking they have ADHD or anxiety. They don't even mention the skin or the asthma or the other health issues. And that's on me to do a really good assessment and start kind of building that to see what is this? Are there other things that could be contributing to the behaviors I'm seeing before I actually diagnose it? So getting to me, I mean, most of us are providers with insurance companies, just like everybody else. There's different resources like Psychology Today, their website. You can go in and choose by zip code, by provider specialty, by age of child. So I could go in and say, in my zip code of 80401, I want a female therapist who specializes in young children, who has experience with ADHD and anxiety and speaks Spanish and takes a Cigna and see who pops up. So there are ways to kind of narrow it and find it. Again, what I find in the community is you can find amazing providers who understand the ADHD, the anxieties, the all of those things. They may or may not have had training and experience in chronic illness, and I certainly didn't. I worked inpatient psych for years before I switched to National Jewish and had to learn the medical. So sometimes you will have to educate them on that, which is a little annoying. But if you have a really good clinician, it's worth spending that time in the first session to provide that understanding that's going to help them move forward with your child.
Great. Yes, and I know like that Psychology Today, that's a great resource for patients, for parents, for children. Also, with a particular your particular insurance, there is that provider list. It doesn't sound like, I know it may not go to the detail that Psychology Today, but at least you can kind of even cross-reference and kind of get a better understanding, because everyone's insurance is different. Some might be better than others. Have you seen is insurance coverage pretty decent for the care that you provide, or is it just really dependent on the insurance type?
It really depends on the insurance type. This is kind of a whole different talk, but we do have the option, and if as consumers, if this is news to you, we have the option in therapy of billing and diagnosing under what's called a health and behavior code, which means I'm working specifically with symptoms and behaviors related to the illness versus mental health codes, which is more the ADHD, anxiety, OCD type things. Not every insurance allows health and behavior codes to be used. So that's something that the clinicians need to know, or you as the parent would want to ask the insurance company. The reimbursement rates aren't that dissimilar, but for whatever reason, a lot of them will only do the mental health codes. But it's always nice to ask, and it's one of the things we've worked a lot with our team here, is that you have to check both codes. Because if I'm working with someone in our medical program and I can start with a health and behavior code and not have to give a mental health diagnosis at first, that's great. That really allows us to not put that label out there and get a better assessment. And I still may end up adding ADHD or anxiety or something else to it, but it doesn't have to be that automatic. As you walk in the door, I need a diagnosis to be able to submit this for your insurance, kind of thing.
So it just really sounds like, when you find, the provider that's covered under insurance, just being able to have, those frank conversations on that, because I know we really, many of us, we aren't like the experts in insurance. So, hearing from you and knowing how it's worked with other families, I think is really important, because we know how important,
It's a nightmare every time, but
yeah.
I've learned some of the loopholes.
Okay, great, great. Thank you so much. All right. Curious about, had another question here, about, is ADHD hereditary?
That is like the $1 million question. So we say it's familiar, meaning that we know that if one or both biological parents have mental health diagnoses, the children have a higher risk. And typically we say about a 1 in 4 higher chance per parent of having that as well. However, we don't necessarily have the genetic linkage to say it's hereditary. So yes, it trends in families is probably the best answer I can give to that.
Okay. So, the parent, they do have ADHD, and they're also raising kids with ADHD. Just really curious if you have any advice for them. Just, make sure you have, able to set and maintain different routines.
Yeah, I often will meet just with a parent at times and say, like, how do we break this down in a way that's doable? Or I used to laugh. We had a physician here for a really long time, and he's an amazing, amazing physician. But he would go in and say like 30 great recommendations to families at rapid fire,
Mm.
right? You need to do this, and when you get home, and and then I always felt like I had to go back in afterwards and debrief and say, okay, all of those gold standard recommendations were awesome. What did you actually hear? Okay, from that, what are the top 2 that you feel you could implement at home that would be the most helpful? And we're going to start there. So sometimes I'm working just with a parent and we're going to break it down. It doesn't mean that those other 28 things recommended weren't really good ideas and would benefit. It just means that we set you up for failure if we expect anyone, let alone a parent who also has ADHD or anxiety or other mental health concerns, to be able to go in and tackle all of that in that manner. I'll also ask families, what's the best way for us to provide information to you? Is it bullet points? Would you rather read it than listen to us? Do you want to review it before we have our discharge meeting and talk with us? How is it going to be most helpful to you to get this information? And then, talking with them about who else is caring for this child, even if it's not another parent. Is there a nanny? Is there the neighbor? Is it grandma? Is it after school care? How do we maybe work there also, so that even if at home we can only do 20% to start, maybe we can add those other things in other environments. So being able to sort all of that and figure out what works. Most adults have figured out systems, even if they weren't diagnosed as ADHD until they were adults. I've had some families I've worked with where I'm assessing the child, and then as I'm getting history, I often ask, who else at home has characteristics like this? Who starts things and doesn't finish them? Who, and parents are like looking, giving each other side eyes and pointing at each other. But they've learned, right? They figured out what works. The most extreme, just as a funny story, I had a child who did have ADHD and we diagnosed it and started him on meds. But as we talked, it was pretty clear that the dad also has ADHD pretty severely, ran his own business, and had an admin that organized his day on Post-it notes around his computer with most important last. So that was the first one he pulled off. So he did it, threw it out, he was done. When the computer was empty, he was done. So beside me joking that he needed to really give her a good bonus, we talked about how he'd adapted. Like, how did he figure these things out? Because he'd never been diagnosed. And about a year later, I ran into them. They were here just medically for follow-up. The dad had gotten tested and started on meds, and the mom was like, thank you. So everybody was kind of functioning a little bit better. But it's common. Not everybody wants medications. Not everybody has been diagnosed. So we just need to talk about, how do you do these things? How do you organize? How do you align things? What helps keep you on track? How do we do this in a way that works for you?
Great. Thank you. I know you'd mentioned that you'll sometimes have, the appointments just with the parent, then you'll have them together, understanding that it's different for every patient. But how many visits do you normally recommend, or do you see, with patients?
It really varies. If you are a day program patient, then it's like pre-scheduled. So if you're coming into our multidisciplinary program, if you're here for 5 days, you would get a behavioral health intake, a follow-up session, and then I'd be part of your discharge plan and I would give you written recommendations. We also have an art therapist who, if the children are 5 or older, would see them at least twice as well. That's like our ideal world. However, skincare, endoscopies, breathing, all those take precedence. So sometimes I get more, sometimes I get less. But it's really varied. And then outpatient, it really depends on the family and what their goals are. If it's just kind of a diagnosis and then I'm referring them for meds, it may only be 1 or 2 sessions. If they are a family who maybe doesn't want to do meds and we're working really hard on behavioral strategies, then it could be a lot more. And I'm not one who runs therapy forever. So it might be we do 5, 6 sessions. You're doing well, you're running with it at home. It's great. Reach out to me if you need me. And then maybe I see them again in 2 weeks, or maybe I don't see them. I have had some kids, not just ADHD or eczema, but I've had some kids I haven't seen for years who now pop back into my schedule because life has changed and developmentally there's been a shift, or there's been a new illness or a family change. So it's really variable.
Okay. And I think I just wanted to go back real quick. I know in your specific situation, you have, you're working with other folks within the hospital, which I think is fantastic. If you are, maybe the parent and child, you're just seeing a pediatrician. So is it typical, like, what is the step then? Like, do they get the assessment from the pediatrician, or does the pediatrician, do they refer you to someone like you or someone else? I guess maybe just really understanding the steps to get that diagnosis and that assessment.
So a lot of pediatricians will diagnose ADHD. And they're pretty comfortable prescribing and managing the typical ADHD medications. Um, Many times that's awesome because it's really hard and sometimes a long wait to get in with a pediatric psychiatrist. So sometimes I'm really appreciative and support that. However, I'm back to the caveat of we need to make sure that there's nothing else driving this. So if they don't have atopic dermatitis and, you know, everything else seems to be checking out developmentally, academically, no family history of other things, no traumas, no head injuries, and it really just looks straightforward ADHD, you can try a medication. The really nice thing about ADHD medications is they're short acting, so you can stop them at any time and you know really quickly if they're working. So it's not like an antidepressant where, you know, it takes 6 to 8 weeks to get to full efficacy and we've started you at a low dose and now we've increased it. And oh, by the way, if you want to come off it, we need to titrate it down. ADHD meds aren't like that. You can start them and stop them. There's no big deal about it. And we know usually within a week if they're helping or not. So in that regard, our pediatricians are really helpful and a really good resource to families. I'm finding more pediatric practices are having a behavioral health person on staff. I don't know if that's a Colorado thing, um, but we're seeing more of it and it's limited. They'll often provide like maybe 5 to 6 sessions so they can do some developmental screeners and some behavioral screeners. But if you need to do full psychological testing, like if we want to do CPTs and computer testing and we want to rule out, you know, is this a processing difficulty and we're doing cognitive testing, then that's going to be with a psychologist or a neuropsychologist. And that's usually a half day to a full day evaluation.
I think this has been really helpful. You know, we really feel strongly at NIA and with our, you know, with our patient community, just, you know, being able to have those frank conversations, you know, with their healthcare providers and it really being, you know, those kinds of shared decisions. So I think that's fantastic. We do have just one more question, and it is, can frequent screen time heavily affect a child with eczema and it seems, I'm sorry, with eczema that seems to have ADHD symptoms. So any
Yes.
kind of correlation between screen time? Okay.
Yes. You know, and it's one of those things I laugh a little bit because we were all naive when we started out in this field. And we used to think like, oh, they can't have ADHD because they're glued to the computer or the TV. Like, look at how well they pay attention. It's not the case, right? With ADHD, we tend to see this hyper focus, and electronics are one of those things. But if you think about what makes them so addictive, it's that constant pixelation, that constant adrenaline, that constant charge. So we do see that it actually can make our executive functioning decline. And I'm not saying all electronics are bad. I'm not an all or nothing person by any means. But we sometimes shoot ourselves in the foot because you hand them the switch because it keeps their hands occupied and now they're not scratching. But oh, now we just realize they've just spent the last 6 hours on that switch. And now when I try to get it away, I'm getting this massive meltdown and they're not sleeping and they're irritable. So we do see that, and we try to limit it. You know, I think APA guidelines are about a couple hours a day of electronics, but it's also age dependent.
Great. Well, thank you again, Jennifer, for helping us get a better understanding of the link between eczema and ADHD in children. And we wanted to thank everyone for joining us today. You can continue your eczema education on our website at nationaleczema.org. You may register for an upcoming webinar or watch the recording of a previous webinar by going to nationaleczema.org/webinar-Wednesdays. On behalf of the National Eczema Association, I thank you all for joining us.